Hello. Hello. Good morning. Hello. Good morning.
Morning. How are you?
How are you? All right.
Yeah.
Are you okay?
Yeah, I'm okay. Thank you.
That's
How are
good.
you?
Fine. Thank you. Um, so I've got your slides here. They're really good. I've been having a look at them, and it'll be a pleasure to go through them with you. Would you like to start with the first slide and just go
Yes.
down? Hello. Hello.
Yeah.
Yeah. Would you like to start with the first slide? Show you.
Yes, I would.
Ah,
I'll just open it up. Closed on.
so there's a bit of noise in the background there. Oh, okay.
I think that's my computer.
Oh, I see.
I can mute the microphone,
Okay.
and then when I want to speak, I'll just turn it on.
All right. No problem. Okay.
Okay, so yeah,
So what I'll
first
do,
slide is good.
oh, good, good. There's also the whiteboard on the agency side, but that doesn't have videos. It's just for writing stuff. So I think we're better to use Zoom. We can share the screen. It's much easier. Yeah. Okay. So if I
Yeah,
share
that's
this,
fine now.
good. If I share the screen, and we can go through them together. So it's loading now.
So, as I understood, the main thing that what the examiner will ask is like what
Yeah.
structures. First of all, what structures in the slide
Yeah.
tell you which organ this is, and just what's in the slide that indicates which disease basically, or indicates a certain disease.
Uh-huh. Got you. Got you. Is it timed? Are you timed per slide, or is it like, are you given like 3 minutes per slide in the exam, or are you?
No, it's more like a conversation between me and the professor.
Oh, that's fine. Okay, I understand. Yeah. For some places, they actually got like timed. Yeah. Thank you. Thank you very much. So if we go on to slide 1, abscending pneumonia, can you see it? Can you see it
Yeah,
there?
I can see.
Very good. Why is it moving? Oh, sorry.
Okay.
Yeah. So basically, you can see a number of lesions that are occurring within this histology. Okay. You can see quite a lot of hyperplasia as well. Hyperplasia around this abscess. So there's the abscess there, but this area here is hyperplasia, which is an increase in the number of cells within the tissue. Hyperplasia.
The darker part.
Sorry?
The darker part is the hyperplasia, where the mouse is.
I mean around this area, around the abscess, yeah. There's a bit of hyperplasia I can see. Not so much any hypertrophy, but nor is there a lot of atrophy. There's more loss of the cells within the abscess. The atrophy is more occurring within the abscess itself. So I think in this one, we've got a indication of hyperplasia and atrophy. That's associated with inflammatory exudates into the tissue, which would cause the atrophy. So that's a shrinking of the size of the cells as the abscess progresses within the tissue. Do you have any questions on that one, or should we move on? Hello?
So, like, the professor would ask, like, which thing in this slide indicates it's the lung, you know? And how would you know this slide shows it's the lung? So I would answer that.
Uh-huh. Okay, so this is certainly lung tissue. Yeah. How do you think this would be indicative of lung tissue, alveoli tissue? How do you think?
Oh,
The air sacs, the alveoli, the spaces, you can see the profusion of blood vessels, a massive amount of blood vessels that would supply the alveoli. Okay. You'd see it a little bit more clearly here. Okay, with the blood supply here. All right, infiltrating some of the alveoli, which you can see just about there. However, there's a lot of accumulation of dead tissue that's happening, hence the blockage of quite a lot of the alveoli. But this area here is where you find quite a lot of the alveoli, that space there, there, there. Can you see the mouse that I'm moving, by the way?
yeah.
Good, good. So the professor's probably going to ask you, how would the inflammatory reaction affect the function of the alveoli? Would he do that, I suppose, yeah?
As sort of a separate part, like, the only issue I have is, like, for instance, I don't know what I'm looking at basically. All I see is just colors.
Colors.
That's what I struggle with. So, like, that
Yeah.
on the top of that slide, it's like a red, really like dark red, like horizontal line, right? Chunk.
This red here, this one, yeah?
Yeah,
This one.
yeah, this one, yeah. Like,
Oh,
what
yeah,
is
yeah.
that like?
Oh, that's a section. That's a transverse section, a longitudinal section through a major blood vessel, and that as well. And that's probably an artery because of the thick wall. Can you see how thick the wall is around the blood vessel there? That wall is really thick, so it's probably an artery. Okay, so it's a section through an artery.
Yeah. And is the whole slide like, is the whole slide?
This is a section of the, if I go back to the first one, of the abscess. So it's taking a blood vessel, which is like there, and a part of the abscess. And what it's trying to show you is that there's a destruction of the alveolar or air spaces as a consequence of the inflammation. And I can see quite a lot of hyperplasia, which is an increase in the number of cell debris. So in this air sac there, the top there, there's lots of bits of cells hanging around inside the air sac. Notice how the air sac has thickened its wall. And there's less space for gaseous exchange due to the increase in the number of cellular particles or debris as a result of the bacterial inflammation. The white blood cells are trying to attack the bacteria and producing a lot of inflammatory products, you see. So it's not the blood vessels that are being affected, it's more the air sacs or alveoli that are being affected. So that's an air sac there, but it's been filled up with all these bits of cell debris. You see? See what I mean?
Yeah.
It's hard to breathe now. Okay. Do you have any other questions before we move on?
We can move on to the next slide.
Good. Well done. Good. Yeah, that indicates some more of the cell debris as seen here. Emphysema. This is a lovely slide. And I like this slide because of the destruction of the alveoli walls. And it's this where I'm holding the arrow there, the mouse. There I can see a type 2 alveolar cell. There's one there. The type 2 alveolar cells help in the repair and maintenance of the alveolar wall. But in emphysema, what happens is the disease, usually caused by cigarette smoking or pollutants, attacks the type 2 alveolar cells, and they can't keep the structure of the cell wall intact anymore. It starts to break down and thins and then breaks down. And as you can see, deterioration there, holes, lesions, and the air sac or alveolus, they increase in size, so the volume of air increases. But as a consequence, it's more difficult to exchange oxygen and CO2 because you're losing blood vessels as well as the walls break down. The capillaries are breaking down, so you can't exchange so much oxygen as easily. Your professor calls it the pores. These are the pores. These pores are the holes, the pores of Crohn. The thinned intraalveolar septi. The septi are the walls. They're thinning, and less chance for blood vessels, less chance for gaseous exchange. The patient eventually becomes hypoxic, less oxygen in their bloodstream, and they really suffer, and heart problems resolve. It's quite a nice one, nice slide there. Have you got any questions before we move on?
Yeah, could you just show me where the pores of Kohn were again?
Sure, no problem. So the wide open pores of Kohn, and we can see quite a few of these pores. Wherever there's a hole in the alveolar wall is where we find the pores. So here's one there.
Yeah.
There's one there. Big one. It's a big one. There's another one there. That's quite a good one. This one. It's developing. Can you see that? Yeah. There.
Yeah.
Okay. Any other questions?
No, that's it.
Sure. Okay. No problem. We move on down. Sorry, I meant to ask, will your professor ask you about the staining of the tissue or not really? Not this.
He can, yeah, he can.
Oh, he can ask about the stain. Oh. Most of the tissue in histology, pathology is H&E stain, the hematoxin eosin stain. However, there are a few specialized stains, particularly for immunological work. This is cancer of the bronchus, okay, squamous cell. So it's more kind of like just below the epithelium. This is just
Sorry to interrupt. Is it okay if I just record it? Because just to see the locations of the stuff when you point the mouse.
No problem. Yeah, no problem. Yeah, no problem.
Because it says I need the permission from the host.
Let me see. Yeah, did you send a? Oh, wait a minute. Directives. Oh. It should be recording. It says it's recording.
Because every time I click it, it says, please request recording permission from the meeting host. So,
Well, I'm going to have to. I'll have to minimize this stuff because
yeah, perhaps on those. Yeah. It's recording on yours maybe, but you can see
yeah,
that.
it's recording this side. I don't know. It's recording this side. It says it's recording. So I'm not sure. Is it not recording your side? No.
No.
Oh, strange. It's definitely recording. So it's got a button here. Stop recording. Pause recording.
Is there any way that you could send your recording to me later?
Yeah, I can do that. Yeah, I should be able to
So I
do
can
that.
just
Yeah,
go over the materials again.
yeah.
Thank you.
It's definitely recording. It says recording, and I can stop recording or pause it. So yeah. Or I can email that.
That's fine.
So here is the bronchus, okay, and this is quite a lot of massive accumulation of carcinogenic material. And a lot of metaplasia, which is abnormal changes. Metaplasia is abnormal changes of cells. And you can, I'll move the mouse a bit. Here is quite a lot of where the metaplasia is, I can see is taking place. This area here. This is more normal type of cells. But here's more the metaplasia, abnormal cells.
So in this slide, are there any features that are typical that shows it's a bronchus?
It's not a very good section. Perhaps this here only this bit here would show it's a bronchus. Yeah.
Which structure is that?
The bronchus is this part of as you know, and that would be the cartilaginous ring. But it's only a little bit of it. It's only this. It's only a tiny section. So that's the cartilaginous ring there. See that? Yeah.
Yeah.
Okay. These blood vessels here are normal. These are normal. Yeah.
Yeah.
Okay. These veins, there's an artery there. These are normal. But the tumor has destroyed the tissue surrounding the bronchus.
So the tumor is more on the left side, right?
The left side, yeah, definitely. Yeah. This is it, yeah. This is it, yeah. This is it, yeah. So that, yeah. Commonly caused by smoking or sometimes by injury to the throat, accidental injury. Sometimes though by also from heavy metal inhalation, heavy metal. We have a closer view of the carcinoma. And here is a very good presentation of, if we have a look, metaplasia. And is massive amount of cells that look like they're going crazy in a way because they're not normally positioned. They're all over the place. And there's a lot of thickening of the tissue, which is a part of this metaplasia. I cannot see any necrosis, which will happen eventually. As the tumor progresses, you get necrosis. But I can see a lot of more metaplasia. So you tell your professor, this is a good example of metaplasia. So as the tumor is probably still localized to the bronchus, it hasn't spread yet into the blood vessels. Yeah, the blood vessels, yeah. It hasn't really spread into that. But once it gets in, they can metastasize. So yeah, this is metaplasia. Okay.
And the structures on the right are blood vessels.
Blood vessels, yeah. These are blood vessels, and these are normal. These are normal. So the tumor is progressing, moving, growing towards this area. Once it hits this area, it's going to start spreading in the bloodstream. Yeah. That's definitely, yeah.
Okay. That's fine.
Okay. Do you have any more questions before we move on a bit to the
No?
epithelium and shall we move on?
Yeah.
Okay. This slide is indicating the bronchus, but particular sections of tissue. The epithelium is deteriorating. Yeah, it's breaking down. There are some bits that are normal. The darker stained bits are normal, but the lighter stained bits are deterioration. There is deterioration. There is normal. So what's going to happen is that as the tumor starts, and remember it's squamous, so it's invading from the deeper, and this is the invasion. So as it starts breaking down the epithelium, you're going to have difficulty in your pressure changes as you inhale and exhale. You're also going to get a lot of mucus accumulating in the inner side of your bronchus. You'll be coughing a lot. See? And with the coughing, eventually you have blood vessels rupture, capillaries break, so you start coughing some blood as well. And I can see this, where the professor's pointed, is definitely where the epithelium is breaking down. Just there. Not all over, but there in particular. Okay. A nice slide that. He says sequential changes. Sequential means gradual changes in sequence. Okay. All right. Do you understand what metaplasia is? Metaplasia. What is that?
Yeah. Is it like the change of cells?
Yeah. And dysplasia?
What was dysplasia again?
Dysplasia is as the cells change, the function of the membranes changes. So the function, dysplasia, displaced change, displacement of the function. So that's what that is. I notice he put calcium. So with time, there'll be a calcium accumulation. We can't really see it in this slide, but with time, as the cancer progresses, you get lots of calcium deposits. And it's associated with the proximity of the parathyroid glands, which are 4 of them on the lower bronchus. And so as the tumor progresses, parathyroid hormone causes the deposition of calcium within the mass. So you would see on further slides calcium deposits. Maybe a professor will ask you that. So you say, what could happen later as the tumor progresses? You say, oh, calcium deposits would happen because of parathyroid hormone. As the cancer affects the function of that gland, it causes deposition of calcium. And in this slide, your professor has started to show us some of the calcium deposition. It's not so clear there, but just about those 2 dark bits, there's the calcium deposition. They just about see it. There's another dark one, round one. There's the calcium. There. We have further degradation, breakdown of the respiratory epithelium. So the dysplasia is happening here quite a lot, as you can see.
Yeah.
Patient going to be coughing. A lot of mucus is going to start building up here. Eventually coughing blood. As the coughing becomes worse, you start to cough some blood as the capillaries rupture. Okay. Here, though, is still some good tissue. Good tissue there and some good tissue over there. Okay. The cancer here is massive, though. This is massive here. Okay. Good slide, that one. Nice slide. Okay, moving down here. Oh yeah, so the bronchioles, going a bit further down into the lungs, the bronchioli are being affected. And this slide shows us the widening of the bronchioles. So let's keep some, let's do that. The widening of the bronchioles and the blood vessel being sectioned quite close to the bronchioles. You can see there. But normally the bronchioles is a round structure, but notice how it's become all elongated, and there's a breakdown of some tissue into the depth of the, into the mass of the, into the space of the bronchioles. There's breaking down of the epithelium. And this epithelium is very important because it's got like microvilli. The microvilli move mucus along. When they break down, it means you can't shift the toxins in your lungs out. And they start to accumulate, and they, so the cancer is growing, but it's causing toxin accumulation in the lungs more and more. So, and all the bits breaking off into lungs means you can't breathe as easily, very itchy, you start coughing more, a lot of coughing, patient coughing a lot. Okay. Certainly a part of the inflammatory response. However, I can see some normal tissue. So that's a normal blood vessel there, normal blood vessel there. Normal tissue here, degradation on the right. Okay. Move down. This mass here shows the consequence of the accumulation of toxins in the lungs, and eventually they're going to start falling down into the lower bronchioles and into the air sacs or alveoli. And in the bronchioles, you get what's called pneumonia. Okay, and it's called peribronchiolar because it starts at the top of the bronchioles and then progresses down towards the bottom of the bronchioles where they connect the air sacs. So peribronchiolar, peri in stages. Now this is a total obstruction of the bronchiole, and there's very little space for gaseous exchange. There's a mass of tissue, it's called sloughed tissue, that's come off the bronchiolar wall, and it's causing very few areas for gaseous exchange to take place, or air to move, if you like, from outside to the inside of the lungs. Such a patient would struggle with their breathing, become quickly hypoxic, will be coughing a lot, struggle with their breathing, very low oxygen saturation, and partial pressures of carbon dioxide will build up, causing what's called acidosis. And acidosis can then affect badly the kidneys first, then the heart, and together with the liver. So it's a horrible disease, causes multiple organ failure eventually. But if we look a bit more closely at the destruction of the walls, here you can see the sloughing of the walls. So the bronchial walls are massively degraded or inflamed, and the microvilli are sloughing off, breaking off into the space of the bronchioles. And that's reducing the exchange of gas. Vascular congestion, yes. The blood vessels here, as the tissue breaks down, the blood vessels are getting closer and closer. Can you see that? Can you see that? They're getting really close, like congesting, they're getting like close. And that can affect the changes in the pressure of the blood. Okay, so the heart's pumping is causing the blood to move around. If the blood vessels are too close, it's going to affect the pressure mechanisms inside there, and that can cause all sorts of problems with gaseous exchange in the lungs, eventually causing those blood vessels to rupture, to break, and bleed. The inflammation also damages the blood vessels, it damages the walls. And the white blood cells inside there will be macrophages, will be exiting to try and attack the bacteria that are invading. But with too many neutrophils and macrophages, you get a lot of pus, and the pus that builds up also causes more problems. Okay. Did your lecturer move on to silicosis? Move down there?
Yeah.
So, can you please tell me what is the main cause of silicosis? Can you remember?
Yeah, it's when it's due to like the environment working condition.
Yeah.
They sort of inhale like for the spores or something over a long period of time.
Yeah, you could inhale spores. You could also inhale fibers, silicosis. You can inhale, like if you're welding, all the bits, the micro bits as well in the weld. Miners, asbestos miners, coal miners, animal people, veterinarians, yeah, they're inhaling the spores, anthrax, all sorts of things can cause silicosis. It's mainly associated with hardening of the tissue, and it says fibrotic nodule. This is the nodule here. This here is the nodule. Fibrotic because of all the fibers that, and you can see them developing, lots of fibers, all these white things, fibrous things are developing. And it's an attempt by the body to try and isolate the silicosis. So it's trying to, how would you say, it's trying to imprison the,
Enclose
them, yeah, like, but as a result, it hardens the tissue too much, and the tissue gets hard, and then it could affect problems with breathing, gaseous exchange, if it happens in the lungs. That's very nice, a very, very, very good picture indeed.
And within the fibrotic nodule, the white parts are the alveolar, right?
The white, these white.
Yeah, these ones. Yeah.
These, yeah. No, these are the fibrous. These are the fibers that are accumulating. The alveolar are much smaller. This we'd have to magnify this to see them. But this is the fibers, yeah.
So the white parts of the fibrous tissue.
Yeah. The alveoli are tiny there. These are the alveoli just there, but we'll have to magnify it a bit more to see them. We'll magnify it, yeah.
Okay.
Yeah. If we magnify it a bit, here we go. Okay. There's all these fibers, and the fibers here, these are the fibers. They form crystalline deposits. This is the alveolus here. That's sort of magnified. But when the fibers accumulate, they accumulate in the wall of the alveoli, and the body tries to encapsulate the nasty bits. It causes the bulges into the alveolus. It means less volume of air in the alveolus, and therefore less chance for gaseous exchange. So can you notice on the top here how your epithelium is degrading, it's breaking down. You see that? Breaking down.
Yeah.
It's very thin there, breaking down here. Because of the pressure from this anthracosis, start pushing up onto that membrane. And the membrane is very delicate, very thin. Probably about 1 micrometer, 1 to 2 micrometers in width, and the pressure on it is causing it to tear, break away.
So if it breaks through the epithelium, it will spread the whole lung.
Yeah, it will, and it'll mean the patient who struggles to actually exhale carbon dioxide, because the carbon dioxide has to diffuse from the blood, past all these crystals, all through here to the epithelium. Because this mass is in the way, it struggles to get to the epithelium. So carbon dioxide builds up in the blood, causing metabolic acidosis. And that causes all sorts of problems with the kidneys, heart, and liver. It's a very nasty disease, usually fatal, this. Occasionally it can be treated with the removal of one lung if it's just in one lung, but normally fatal. Yeah. It's not so quick, it happens over time as well. Sometimes it can happen over 25 years. Okay.
Okay.
So, very good. So if we move on to the pneumonia, and pneumonia can be caused by a variety of things: bacterial, inflammatory. It can also be caused by susceptibility, if you like. And if I'm reading down here, pulmonary parenchyma. Yeah. And if we look at the parenchyma, sort of well-formed, nice uniform shape, if you like, there. But the one problem is that there's accumulation of lots of dead cells, and we call that exudate. So the dead cells are increasing. So there's a lot of what we call ischemia, and ischemia causes the death of cells. So as the exudate increases, you get more and more of this ischemic property happening, and it causes the breakdown of the tissue. This is a good example of a looks like a capillary. Should have looks fine. Blood vessel that looks fine. But we can see some, if we go further down towards the lower right-hand side, we can see the destruction here, happening here. Over there, this area here.
What's happening there?
Just over there, there's destruction, and that's due to the a lot of things. The white blood cell response, trying to attack the bacteria, and that causes a lot of inflammation. And inflammation is causing breakdown of the cell walls. Okay. It's also causing accumulation of lots of debris within the cells. So these purple bits here, there's a lot of cell debris and death of cells as well. So some of the cells are beginning to die. Now in the middle there, you've got a blood vessel. Around another blood vessel, but around there, you're getting cells that are beginning to die. And that's as a result of ischemia, sometimes called hypoxia. So the cellular accumulations in this disease are significant. And as they die, it means there's less chance for gaseous exchange if the pneumonia progresses into the alveoli. Okay, so less chance. It talks of fibrin, fibers, yeah, eventually what you're going to have is fibrous accumulation. Fibers trying to encapsulate the area of infection. But as the fibers build up, it means it makes the walls of the alveoli of the bronchioles really rigid. If they're rigid, it means you can't exchange your gas very easily anymore. So you struggle to breathe. I think we need to move down to see the destruction a bit more clearly. So this area here, is, as I said, is destruction. And here we can see some more of the destruction happening here. This is a classic example of destruction from pneumonia. Yeah, the breakdown of the walls. But notice how around these areas here, around this area, there's a lot of filling of the alveoli now, filling. And the filling is, as your professor says, the pink exudate, the pink exudate. He also says there's some erythrocytes and the hepatinization. Yeah, okay. So as the alveoli begin to fill, they start to put pressure on the walls of the alveoli, causing disruption of the capillaries. And the red, let's look for the red. The red, just there's red there, red hepatinization, some red there. red there. The grey red there. The grayer areas are more, these areas here, the grayer bits. Okay. So it's mainly in the walls. So remember when you see erythrocytes, you think about the walls of the alveolar. That's where the capillaries are. But keep in mind that some of the capillaries are breaking down. Hence this classic section there where we have bleeding of the capillaries. This is a good example here of the fibrin that's accumulated, the fibrous tissue, the hardening, just over there. So that's a fairly good slide. Yeah, quite a lot of detail there. Did your professor explain how you could get Croup-less pneumonia?
Yeah, I think as long as we can just identify where the grey and red hepatization is, it'll be fine.
That's fine, no problem. Sorry, do you have any questions on that before we move on to the magnifying?
No, it's fine. We'll move to the next one.
Okay, good. I'll just make that, sorry, a little bit bigger. There we go. So the grey section, the hepatization. Now, if we look again at the grayer areas, there's some example of the grayer areas there. That grey areas there in the alveolar wall. There.
Is it the white parts you're pointing at?
The darker, whiter bits, yeah, the darker, whiter bits, just over there, there, move up there, there. So it's over there. Can you see that? Just over there.
Yeah.
Just there. That's it. Yeah. Now he says pink fibrous exudate with some leukocytes. Leukocyte invasion. Okay. Now leukocytes are secondary defense following the neutrophils. But the leukocytes tend to be destructive to the tissue. So any infected cells, they'll try and destroy, digest, destroy. And in that case, we should be seeing spaces or holes develop in the tissue. And we can see lots of holes now starting to develop, small round holes. There's one, there. You can see these little holes now developing in the tissue.
Yeah.
Due to the destruction from the leukocytes. So this is a big problem for the patient now because it means it's more difficult for carbon dioxide oxygen to transverse, to move across. And the space means loss of functionality of the tissue, breaks it down. Well, this unfortunately can cause death quite rapidly. Yeah. As you can see here, the holes are really major now. Lots of these holes occurring all over the tissue. Again, the grey areas here, the grey hepatomerization there. These are the grey areas. The pink exudate is just this, all this here is pink. No. So very hard to exchange gases in that tissue, very hard. Alveolar is almost blocked, almost totally blocked. Any questions? Sorry, before we move on.
Just say, can the patient recover these alveoli potentially? Can the exudate be removed?
Say it again. Sorry, I didn't hear.
Naturally, just say if the pneumonia is treated,
yeah.
can the exudate be sort of can these alveolas be not replaced, but treated?
Yeah, good question. It depends on the extent of the pneumonia. You need an infusion, usually an intravenous infusion of a variety of antibiotics. And if you catch it stage 1, just about stage 2, stage 1, you can cause recovery through treatment. But once it gets to halfway stage 2, 3, no. Eventually what happens is you start getting fluid on the lungs, fluid builds up due to the inflammation, and death results. In this case, it looks a bit severe, to be honest, because once you get the holes in the tissue, it's a bit very hard to treat, you see. And you can't do a lung transplant either. So unless if it's just one of the lungs, fine. But if it's both, which usually is the case, then usually death results. Yeah, unfortunately. This is a very interesting slide of a fungal infection, aspergillosis. And you can see it centrally there, but all these radiating, the purple bit, all these radiating bits of the hyphae of the fungus are growing outwards from the central, and they're seeking nutrients, but in the process they break down tissue. See the space there, and the inflammation around this is massive. This red, pink, dark red, pink is inflammation, yeah, massive around this mountain of fungus growing there. The radial arrangement of the hyphae, so it's circular radial, that gives it support. Okay, so it's not easily shifted. It stays in place and just grows outwards. The mycectoma, because it's central, it's like a mycete, like a hill. It's sort of like that shape. It's hilly, and then it's growing outwards like that. So mycectoma, causing destruction of tissue around itself. The necrosis is very evident here, liquefative necrosis. And necrosis is death of cells due to the hyphae killing them, but also stealing their nutrients. So the hyphae are getting into blood vessels, stealing nutrients, getting into the cells, stealing their nutrients, and causing death of cells. In order to isolate it, fluid builds up. The more the fluid builds up, the more problems you have with breathing. So if this is in the lungs, you can have a big problem with your overall breathing mechanism. And the hyphae can easily spread, see, very easily spread. So a patient can be coughing and spread them as well. Let's have a bit of a closer look, a magnified look at the central mycectoma. As I said, it's a hill. It's a hilly type of condition. The radiating strands are interesting. Okay, seeking out nutrients, destroying tissue around, causing fluid to build up. This is necrosis, destruction of the tissue or cell. Now, if the professor asks you, why is that necrosis? Then you'll say to him, okay, let's look at the top left-hand side. Now, these cells here are okay. Okay, you can just about see a nucleus there. These are okay. But these cells are not okay. They're breaking down. And the cell walls is broken down. Bits of the cell are coming out. The nucleus is deteriorating. The whole cell. This is a start of one breaking down. Not yet, but these are broken down. Yeah. So cells are breaking down. All right. So that's necrosis. And of course, when the cells break down, they die. And that's necrosis for you. Hemorrhage in the lung parenchyma does happen. So as the cells break down, so the capillaries are broken down, and the capillaries start to obviously exude their blood, and they start to bleed. Problem with such a patient is they get lots of blood clots. In the bleeding causes lots of clots as well. So there will be some coughing of blood, but there will also be these clots building up, which causes further further restrictions to the movement of air.
Yeah.
You can get this condition from living in damp environments from animals like cattle and sheep, and you can also get it from if you're immunocompromised, so you're suffering from a disease like HIV/AIDS. This is a common condition in such patients. Okay, very good. How are we doing for time? Okay, got enough time. Good. Now the salivary glands, really important, and there's six sets of them in your face area. Okay, some under the lower jaw. Adenoma of the salivary gland is usually caused by chewing of tobacco or cigarette smoking. Not always, but mostly. Now, what are we looking at? We're looking at a thickening of the tissue. And this thickening of the tissue you can see here all the way around there. It's trying to enclose this massive blue area here, where we find the growth of this cancer or adenoma. There's a lot of inflammation, the pinkish, reddish area here. There's a bit of inflammation occurring, trying to, in a way, trying to attack the tumor, the adenoma, and
The blue part is the adenoma, yeah.
yeah, and you get these what's called tumor necrosis factor. It's produced by one of the leukocytes, say one of the T cells, and when those T cells produce tumor necrosis factor, they try and prevent the tumor from growing, but in the process causes massive inflammation around the tumor, and inflammation causes other problems, like prevents or slows the production of the gland producing saliva, or the exchange of salts, sodium chloride exchange and potassium exchange into and out of the salivary gland cells. Bunches of glands with various morphology. They can see the bunches of glands there. Now, they are breaking down. As the tumor is attacking them, they're starting to break down. They're not working as well anymore. So this top left-hand corner is the destruction of the glandular cells. So the fibrous capsule, destruction of the glandular cells, loss of function. But I've noticed so that this blue bit has also beginning to form here. Can you see there as well? So
yeah.
It's spreading rapidly through the salivary gland. And that's a problem with the adenoma. It's very rapidly spreading in glandular tissue, particularly in glandular tissue. Now, such a patient would definitely need chemotherapy, probably radiography, and in some cases surgery to remove the affected gland. But chemotherapy would certainly be advised.
And what are the structures on the bottom right?
The bottom right, okay, fair enough. These here, this is normal tissue, yeah, normal. And this is part of the salivary gland. So I can see it's got normal, yeah, the normal cellular components to it. You can see some of the nuclei there, normal structure, normal tissue structure. This part here, though, is the cancerous area. Okay. I think the space is more the when the slide was prepared, sort of it broke away. This isn't really part of the disease. So when the slide was prepared, that normal tissue broke away and it has been sectioned. Okay, because the cancerous part is really, really hard. So when you cut it, sometimes when the knife cuts the hard bit and then gets onto the soft bit, it causes the soft bit to tear away a bit. So if you ask you about that, just say that's during slide preparation. Okay. Interesting slide that. Let's see if we can see it a bit more in some more detail. Yes. Here's the hardened area of the tumor, really, and this is the fibrous capsule trying to encapsulate the tumor. Lots of inflammation. The lower left, sorry, if I move that up a bit. Lots of loss of glandular function there. Lots of inflammation There's lots of inflammation all over the place. Is inflammation, I can see. Wherever there's the pink areas, the pinkish is inflammation. Massive. The cancer, the adenoma, is resisting the fibrous onslaught. Can you see this area here? It's pushing on the fiber there. It's trying to get past the fiber, if you like, to grow, and it's in places succeeding. It's getting through there, starting to break through. So although the fiber helps, eventually the cancer breaks through and spreads into the bloodstream. I can see lots of necrosis as well. Necrotic tissue where there's spaces here, there's necrosis beginning. Okay, and notice where there's necrosis, it's individual holes. This is glandular tissue, they're all together, but the necrosis is more individual holes. And usually round holes when necrotic tissue, usually. So yeah, this is certainly a serious, very, very serious. This is well advanced, well advanced adenoma. You see here. So what we're looking at is as the professor said, the fibrous hyalinization. Bunches of glands are seen. There's bunches of glands there. They are kind of like nestling or nests of the glands, if you like. The hyalinization is an attempt to try and prevent the, how would you say, the metastasis of the tumor. So prevent the cells of the tumor from their destructive pathways, if you like. And kind of like becomes a blue type stain type tissue. So wherever there's a big blue mass is the hyalinization. Okay? There's a lot up here and some there. A lot of hyalinization at the top here. Okay. So this is a good one at the bottom left, hyalinization. It's really good there. There is some indication though of, see these channels there, they still look a bit normal. Still a little bit normal in the salivary gland, so they'll be channeling the saliva. But there's lots of inflammation. Now the red bits there is inflammatory exudate. So there's lots of white blood cells coming to try and stop the growth of this tumor, this mass, this tumor mass, but struggling. This is what we call solid epithelial nests. Solid epithelial nests is the epithelial tissue, which you can see here around the salivary caniculi, that's beginning to try and fight the cancerous cells, and the nesting causes inflammation. And inflammation then causes problems with the production of saliva and all sorts of other problems. See, also very painful because salivary glands are well innervated, so the gland starts to swell in size, causes a lot of pain to the patient as well. Any other questions? If we look at it more detail.
That's fine.
Oh, very good. Do you have a question on this? You can see the epithelial cells are quite nice there, quite normal there. This is the salivary duct or caniculi there, epithelial cells. You can see the blue bits of the haline. The blue bit is trying to, the haline tissue is trying to stop the movement of the tumor, which is obviously coming from this side up. So this here is the tumor here, just called part of the tumor. It's trying to spreading upwards towards the left. But as it's spreading, you can see it's destroying some of the epithelium there. It's destroying there. This is necrosis there, causing necrosis. It's definitely here, causing a problem in here with a lot of cellular exudate forming inside the salivary canal there. blocking it. There's a nest. There's a lovely nest there. That round bit is a nest. Okay, and the nest is the attempt of the leukocytes to try and stop the cancerous cells that causing inflammation. You can see some fluid above it there, inflammation around the nest. So yeah, good. Yeah. So cellular accumulations result in cell damage, and cell damage results in death of the tissue, which is called necrosis. Okay, so don't forget that as well. All right. So any questions before we move on? Or are you happy with that?
That's fine.
Okay, yeah, it's not the best of slides. This is because why I say that is because there's lots of cellular debris in all over the place, so it's hard to see all the areas. You can see some fibrosis. This is fibrous tissue, long strands, extended nuclei. This is fibrous tissue there. Glands with various morphology. Well, most of the glands are necrotic. They're breaking down. This is necrosis there. Destruction of the cells, necrosis. All the blue bits is the hairline tissue, trying to prevent the spread of the tumor. This is an example of a necrotic area inside the gland. There's a lot of inflammation surrounding it there, pink area. But generally, if you look throughout the tissue, most of the cells are dying. See, spaces, or lack of nuclei. There's a lot of death of cells throughout, and that's due to the invasive properties and the stealing properties of the adenoma, as it steals the nutrients. And also because it's growing in size, it's putting pressure on the mitotic cells, the dividing cells, causing them to die as well. Yeah, so that's that. Here we find the further progression of the adenoma, but the exudate is massive now, massive pink exudate. Stromatization occurs within the gland because when there's a lot of exudate, it means it's very hard to produce your normal expulsion or your normal saliva. Hence, stromatization. It's the thick exudate means as well that it's going to be putting pressure on the surrounding tissue. Okay, it's building up. It starts like a balloon. It starts pushing as it builds up, but it also starts finding its way into to block blood vessels, to block salivary channels, and to block other areas within the gland, as well as causing pressure on the gland. So the gland starts to swell, and that causes a lot of pain. These sites, though, can also be sites of bacterial invasion as well. So you could get a secondary bacterial infection of these areas as well. So they become more and more of a problem as the adenoma progresses. In such a patient, it's probably likely that he would need, that extent, he's probably going to have radiotherapy to actually burn it away. But that will cause a loss of quite a lot of the rest of the salivary gland as well. But hence, better to get rid of the tumor than to die, because eventually it's going to spread into the surrounding areas and probably into the bloodstream. So you can tell your professor a lot about this as well. You can tell him quite a lot as to why this is a problem. Okay, the stromatization. Any questions?
The purple bits between the like really light pink stuff. What is that? Where the mouse is right now.
That one.
No, like the dark purple between the. Where there's lots of nuclei. Is that the gland tissue?
Yeah. Oh yeah.
Yeah, this region.
Yes, that's. If I have a look, yeah, that's part of the gland tissue. I can see the nuclei there. It's part of the gland tissue. But this bit here is the invasive haline tissue. It's coming in, and here is the haline tissue. Notice as the haline tissue enters, it destroys the normal cell, the normal cells, the normal gland tissue. Yeah, you see it? It's like loss of the normal cells there.
Yeah. So what is the really light pink stuff then? Is that a gland as well, or?
The pink stuff, yeah. This pink stuff, yeah.
What is it?
Oh yeah, what is it? The pink stuff is, it's exudate, or it's part of your inflammation. So as the cells die, white blood cells create an inflammatory response, and exudate results from a mixture of dead cells and mucus and that sort of stuff. It's all mixed together. And exudate is it's an attempt to try and kind of localize infection, but because the cancer is spreading throughout the gland, it can't really localize it. You see what I mean?
So does that mean where the light pink stuff before there was glands as well?
Yeah.
Okay.
Yeah. It was glandular before, but now necrosis has happened, and the necrotic area is filled with the exudate. Yeah.
Okay.
These guys are going to push really a lot on this tissue. As these grow in size, they're going to push on this tissue and cause further death of this tissue. So these guys grow in size, they're going to cause lots of other cells to die. Yeah.
I think the time is up.
Okay.
Yeah, I did mention to you my exam is on Friday. So
Friday.
Yeah.
Okay.
In like 5 days.
In 5 days. Yeah. If you want further lessons, no problem. I can organize that.
Yes. The only thing is on the schedule on Tutor Hunt, it mentioned next week Sunday.
Oh, yeah. What I'll do, I'll change that, because that Tutor Hunt, it automatically put that as a weekly thing. What I need to do is change it to a one-off thing. Yeah.
Yeah. Okay. So then when are you free then?
Let's have a look at my diary here. I'll be free tomorrow if you want, same time.
Tomorrow, same time. Yeah. That sounds good. And then we'll take it from there. So I'll tell you tomorrow.
That's very good. I agree. Yeah, that's very fine. That's no problem. Yeah. So I'll tell Tutor Hunt tomorrow at 11 for you.
Yeah.
All right.
So because the card details went by Tutor Hunt, when will it take out the money? Because it doesn't. How will it work? You know?
They sent me a message that they're processing the money. They're processing it. Yeah.
Okay.
I don't know, because it's Sunday. Maybe because it's Sunday. Perhaps it's tomorrow. It'll come out. Yeah.
Okay, that's fine. So tomorrow, same time.
Yeah. Sorry. Do you like Zoom? It's nice, isn't it? Zoom's more.
Yeah, Zoom is fine.
So we can use that again. All right.
Will the code and the password everything be the same, or will you have to create a new one?
No, I'd have to create a new one, because this was a one-off. Yeah, I'd have to create a new one. Yeah. I'd create a new one. I'll do that. Yeah.
That's fine.
Okay,
so then I'll just wait for the email.
Very
and
good.
the final thing is the recording, because there's a lot of visual stuff needed for this.
Yeah, I'll save that and try and email it to you. Okay.
Thank you so much. Thank you so much.
So all the best. Take care. Bye.
You as well. See you tomorrow.
Bye. All right. Bye.